Since most of you guys asked me to make a second part video on Staphylococcus aureus, I thought I'll do it today. In this video I'll be talking about the clinical features, laboratory diagnosis, drug resistance, methicillin resistant Staphylococcus aureus, vancomycin resistant Staphylococcus aureus, and Coagulase negative Staphylococcus. If you're new to my channel, hit the subscribe button and the bell icon nearby to get notified as soon as I upload new videos. And remember that I make new videos every week. The reference for this video is Dr. Apurva Shastri's Medical Microbiology textbook. It's such an amazing textbook. I provided the link for this textbook in the description of this video. Make sure. Clinical features. Staphylococcus aureus can literally affect any part of the body starting from head to toe. Okay, so they are known to cause skin and soft tissue infections, musculoskeletal infections, respiratory tract infections, bacteremia, urinary tract infections, and various toxin-mediated illnesses. First, let's talk about the skin and soft tissue infections. They can cause furuncle, which are commonly known as boils. They can cause carbuncle, cellulitis, which is infection of skin and the subcutaneous tissue. They can cause hidradenitis suppurativa, which is actually a recurrent follicular infection in areas which are rich in apocrine glands, for example axilla. And they can also cause botryomycosis, which is a condition which resembles mycetoma. I'm sure most of you guys will be aware of mycetoma. If you guys want me to make a clear video on mycetoma, feel free to comment below and I'll be happy to make it. This picture shows folliculitis, which is inflammation or infection of the hair follicles. This picture shows impetigo, in which there is honeycomb crusts lesions over the face. And remember that Staphylococcus aureus commonly causes mastitis in breastfeeding women. They can cause various musculoskeletal infections like septic arthritis, osteomyelitis, pyomyositis, and abscess like psoas muscle abscess. They can commonly cause respiratory infections like ventilator-associated pneumonia, post-viral pneumonia, for example, following influenza infection. They can cause empyema, which is a condition where there will be pus in the pleural cavity. They can cause pneumothorax and pneumatococcus. Pneumatococcus is a condition where there will be air-filled cavities within the lungs. Okay, so Staphylococcus aureus is one of a very common cause for pneumatococcus. Bacteremia. When Staphylococcus aureus bacteria invades the bloodstream, they can literally spread to any organ, causing secondary infections. Okay, so when they invade the bloodstream, they can cause various manifestations like sepsis and septic shock, central line associated bloodstream infections, and from the blood they can spread to various organs like kidney, joints, bones, and lungs. They can also cause infective endocarditis. They can also cause urinary tract infections and pyelonephritis. This is most commonly secondary to bacteremia. Toxin-mediated illnesses are toxic shock syndrome, food poisoning, and staphylococcal scalded skin syndrome. I've explained about these conditions in my video, the first part video of Staphylococcus aureus. The link is provided in the description of this video as well as in the comment section. So after watching this video, make sure to go check it out. If you're enjoying this video, make sure to hit the like button so that I'll know that you'll really like this video. Now, community-associated methicillin-resistant Staphylococcus aureus. Now, they are also commonly known to cause skin and soft tissue infections. In addition to that, they can cause severe infections like necrotizing pneumonia, Waterhouse-Friderichsen syndrome, and necrotizing fasciitis. Now let's talk about lab diagnosis of Staphylococcus aureus. Now, first of all, to diagnose any infection, you need to collect any sample. In this condition, the sample which you're going to collect for diagnosis of Staphylococcus aureus infection is going to vary from condition to condition. I'll talk about it in the next slide. With a sample, you can perform gram staining, you can grow them on culture media, and from the culture media, you can take swabs and perform, you can take smears and perform culture microscopy, and you can perform various biochemical tests, typing like bacteriophage typing, and antimicrobial susceptibility testing, which is helpful in treating the patients. Sample collection. It really depends on site and nature of the lesion. For example, if a patient has suppurative lesions on the skin, which are caused by Staphylococcus aureus, all you need to do is collect the pus from the infected site and you send it for culture or for gram staining. If the patient has urinary tract infection, you obtain the midstream urine and you send it for culture. If the patient has, let's say, bacteremia, you obtain the blood from the patient and you send it for culture. So it really depends on the site and nature of the lesion. Okay. From the obtained sample, we perform gram staining. Even a real newbie or a beginner in microbiology will know the fact that Staphylococcus aureus is gram-positive cocci in clusters. This is how they really look in gram staining. Culture. There are various ways to various culture media for growing Staphylococcus aureus. So the prerequisite is that they have to be inoculated in culture media and that they should be incubated overnight at 37 degrees Celsius under aerobic conditions for better results. They can be grown in nutrient agar slope, blood agar, McConkey agar, liquid medium, peptone water. Liquid medium is actually peptone water. Okay, and there are certain specific media for specific culture media for Staphylococcus aureus, on which I'll be talking about in the next slide, which is really very important. On nutrient agar, as you can see here, there are these golden colonies. These are smaller in size, which circular in shape, smooth colonies, which are convex and opaque. So they are golden yellow in color because of production of golden yellow pigment, which is known as which is made up of beta carotene. Okay, so this is what you get in nutrient agar. In nutrient agar slope, it actually produces growth of the bacteria, which has appearance of oil paint. In blood agar, you can see the growth of Staphylococcus aureus bacteria, which is surrounded by narrow zones of beta hemolysis. In McConkey agar, you can see small pink colonies of Staphylococcus aureus bacteria due to lactose fermentation. In liquid medium like in peptone water, they produce uniform turbidity. Now this is the really important topic. Selective media, culture media for Staphylococcus aureus. This is really important when the sample obtained from a patient has many other bacteria in addition to Staphylococcus aureus bacteria. In this condition, there will be so many bacteria which will cause confusion in the diagnosis. What we're basically trying to do in the highly selective media is that we're trying to add salt, which is sodium chloride. Sodium chloride is known to cause many bacteria which are present along with Staphylococcus aureus in the sample obtained from patients, but Staphylococcus aureus is resistant to sodium chloride, so it is not killed by sodium chloride. So it's helpful in eliminating the other bacteria and obtaining a selective diagnosis of Staphylococcus aureus. The various selective media available are mannitol salt agar. In mannitol salt agar, it actually contains nutrient agar with 7.5% sodium chloride. Okay, as the name suggests, it also has salt in it, and the indicator used in mannitol salt agar is phenol red. What happens here is that if Staphylococcus aureus is present, it produces yellow colored colonies due to mannitol fermentation. The next selective media is salt milk agar. Salt milk agar contains nutrient agar and 6.5% sodium chloride. In addition to that, They also contain 10% skimmed milk. Another selective media is Ludlam's medium, which is a combination of lithium chloride and telluride. Now, these are the selective media for Staphylococcus aureus. Culture smear microscopy. Once you obtain the bacterial growth on the culture media, obtain smears from the culture media and perform gram staining, and again you can see gram-positive cocci in clusters. In hanging drop test, you can observe non-motile cocci. Biochemical tests. These are really important tests. Now, in order to make the biochemical tests easy to understand, just try to keep following what I'm saying from the beginning, alright? So, how are the gram-positive bacteria classified? The gram-positive cocci are classified generally as two families, Micrococcaceae and Streptococcaceae. First, we have to differentiate Micrococcaceae from Streptococcaceae. Okay, the test which is required for that is catalase test. Micrococcaceae are catalase positive, but Streptococcaceae are not. So first, remember we are performing catalase test. Catalase test helps to differentiate if it is Streptococcaceae or not. Okay, so if it is catalase negative, we are sure that it is not Streptococci, whereas it can be Micrococcus or Staphylococcus, which both belongs to Micrococcaceae. Now there is one more test known as Hughes and Leifson oxidative fermentation test. Now once we confirm that it is Micrococcaceae, we need to differentiate between Staphylococcus and Micrococcus because both of these belong to Micrococcaceae. In order to differentiate them, we perform this Hughes and Leifson oxidative fermentation test. This test helps to differentiate Staphylococci from Micrococci. Okay, so the Staphylococci produces a fermentative pattern, whereas Micrococci produces oxidative pattern. Once we confirm the presence of Staphylococci with these tests, we proceed further. There are further tests which helps to differentiate the species within the Staphylococcus. For example, it helps differentiate Staphylococcus aureus from the coagulase negative Staphylococci. The tests commonly used are coagulase test, which is further classified into slide coagulase test and tube coagulase test. And this is one of the very important tests you must know. Heat stable thermonuclease test, DNase test, phosphatase test, mannitol sugar fermentation, potassium telluride agar, gelatin liquefaction, protein A detection. Okay, so I'll discuss a little bit about coagulase test here. This is the interpretation. This is how the slide coagulase test looks like. If there are no clumps present, it is coagulase negative. If there are clumps present, it is coagulase positive. This is slide coagulase test. Now here you can see the presence of clot in tubes indicates coagulase positive by tube coagulase test, whereas if clots are not present, it is negative on tube coagulase test. Now I'll tell a little bit about coagulase test in the next slide. Heat stable thermonuclease test is positive in case of Staphylococcus aureus, whereas negative in case of coagulase negative Staphylococci. DNase test. There is an agar known as DNA agar on which Staphylococcus aureus will produce clear halo surrounding the colonies. This is because of their ability to digest DNA. Okay. Phosphatase test. I'll describe about phosphatase test in a bit detail in the upcoming slides. Mannitol sugar fermentation test. Staphylococcus aureus has the capacity to ferment mannitol sugar. In potassium telluride agar, black colored colonies of Staphylococcus aureus are produced. By gelatin liquefaction test, Staphylococcus aureus is again positive. Protein A detection is also another test which is used to differentiate Staphylococcus aureus from coagulase negative Staphylococci. Okay, so tube coagulase tests detects free coagulase. Alright, so this test is used to detect free coagulase. This test can sometimes give false positive results. This is because if you're adding citrate to the plasma sample obtained from the patients, if some other bacteria like Pseudomonas is present, it can utilize the citrate to grow, and it can produce clots which resemble the clots produced by Staphylococcus, giving a false impression that Staphylococcus is present. That's why citrate should not be used in plasma samples for performing tube coagulase tests. Slight coagulase test detects the presence of clumping factor, which is also known as bound coagulase. Phosphatase test. Staphylococcus aureus containing sample if inoculated in phenolphthalein diphosphate containing media. What happens after that is Staphylococcus aureus has this phosphatase enzyme which can break down phenolphthalein diphosphate to release phenolphthalein. Okay, so free phenolphthalein is released. When ammonia vapors are passed over this, ammonia reacts with phenolphthalein to form pink colored colonies. This is the interpretation of phosphatase test. Typing. Typing is very important only especially on the epidemiological point of view, and there are various methods to perform typing. This includes phenotypic methods like bacteriophage typing, antibiogram typing, genotypic methods like PCR RFLP, which is restricted fragment length polymorphism, ribotyping, PFGE, which is pulse field gel electrophoresis. Now, the most important of this, for exam point of view, is bacteriophage typing. So I'll be making a short discussion on bacteriophage typing in the next slide. Bacteriophage typing. This test is based on capability of different phages to lyse the strains of Staphylococcus aureus. Now, how is the naming of these strains done? Now, let's see this example. Phage type 80/81 is known as epidemic strain of Staphylococcus aureus. This is not just an example; this is actually a fact. Phage type 80/81 is known as epidemic strain of Staphylococcal aureus because they are responsible for many outbreaks of Staphylococcus aureus in hospitals. How are they actually named? Let us consider a strain of Staphylococcus aureus. If it is destroyed or lysed by a bacteriophage, actually these bacteriophages are named by numbers. Okay, for example, bacteriophage type phage 80, phage 81, like that. Okay, so if a strain of Staphylococcus aureus is lysed by phage 80 as well as phage 81, it will be represented as phage type 80/81. Alright, this is how the naming is done. Bacteriophage typing and other methods of typing is usually done to subclassify the Staphylococcus aureus bacteria into subspecies. As I told you, bacteriophage typing is used for epidemiologic purposes. Antimicrobial susceptibility test. This is done on Mueller, Hinton, agar to find out susceptibility of the bacteria for various antibiotics, and this is very helpful in the treatment of patients. This shows testing of antimicrobial susceptibility test. Drug resistance. Now, how do Staphylococcus aureus develop resistance to the antibiotics? There are two main mechanisms. One is by producing an enzyme known as beta-lactamase enzyme, which is plasmid coated, and this enzyme has the capability to break down the beta-lactam antibiotics like penicillins, thus providing resistance against these kind of antibiotics. Another mechanism is by alteration of penicillin binding proteins, which are abbreviated as PBPs. Actually, drugs like penicillins will bind to these proteins, the penicillin binding proteins which are present on Staphylococcus aureus bacteria, and inhibit the cell wall synthesis. Okay, so since there will be alteration of penicillin binding proteins, the penicillin antibiotics cannot bind to these receptors, these proteins, and hence they cannot carry out the action. These are the two common mechanisms by which these bacteria develops drug resistance. Now let's talk about methicillin resistant Staphylococcus aureus. Methicillin resistance is mainly mediated or produced by or encoded by a gene known as McA gene. This alters the penicillin binding proteins in the Staphylococcus aureus bacteria to another form known as penicillin binding protein 2A form. This form leads to a development of resistance of the bacteria to the penicillin antibiotics. Okay, so the methicillin-resistant Staphylococcus aureus usually causes two types of infections, known as community-associated infections or hospital-associated infections. The community-associated methicillin-resistant Staphylococcus aureus infections are usually more virulent, whereas the hospital-associated methicillin-resistant Staphylococcus aureus are comparatively less virulent but are multi-drug resistant. Diagnosis of methicillin-resistant Staphylococcus aureus is done by antimicrobial susceptibility test by using cefoxitin disc, and polymerase chain reaction can help to detect the McA gene. Treatment of methicillin-resistant Staphylococcus aureus is mostly by vancomycin. There is another group known as VRSA, which stands for borderline oxacillin-resistant Staphylococcus aureus. Now, this resistance is actually encoded by a non-McA gene mediated process. This bacteria has some amount of resistance to oxacillin, and due to that there will be hyperproduction of the resistance to oxacillin is due to hyperproduction of the beta-lactamase enzyme. Now let's talk about vancomycin resistant Staphylococcus aureus. This resistance to vancomycin is thought to be mediated by VAN-A gene. This gene is thought to be acquired from vancomycin resistant strains of Enterococcus faecalis by horizontal conjugal transfer. The drugs which are active against vancomycin resistant Staphylococcus aureus are linezolid, telavancin, daptomycin, and quinaprisin. There are preventive measures to control Staphylococcus aureus infections or even prevent them to some extent. First of all, the medical personnel like doctors, nurses should practice proper hand washing techniques to prevent the spread of infections to the patients. There should be screening of the healthcare workers for the carrier state of methicillin-resistant Staphylococcus aureus, especially during outbreaks of infections in hospitals, and the most common preferred test method for this purpose is using mannitol oxacillin agar. Treatment of carriers should be done to prevent the spread of infection to further patients, and the doctor should stop overusing the antibiotics unnecessarily. For example, if a patient comes with an upper respiratory tract infection, which is most commonly caused by viruses, unnecessary prescription of antibiotics leads to development of resistance to these antibiotics. That's why all the doctors should start using antibiotics more judiciously. And there's this technique known as bundling, which actually means performing various medical procedures in a prescribed set of in a prescribed fashion. For example, there are certain steps to administer central IV lines or administering intravenous catheters, etc. And if these procedures are followed, there will be less consequences or less chances for secondary infections to develop. Now, a brief discussion on Coagulase negative Staphylococcus. The main important Coagulase negative Staphylococcus are Staphylococcus epidermidis, Staphylococcus saprophyticus, Staphylococcus lugdunensis. These were thought to be just commensals present on the body, but later they were found to be the culprits in various infections. The most important of them all is Staphylococcus epidermidis. So I'll discuss about that in a bit detail. But remember that Staphylococcus saprophyticus can cause urinary tract infection, especially in sexually active young women. And Staphylococcus lugdunensis is thought to be associated with endocarditis and osteomyelitis. All right. So let's talk about Staphylococcus epidermidis in a bit detail. Staphylococcus epidermidis. The most common infection caused by them is prosthetic devices related infections. For example, they are known to form biofilms over the prosthetic devices like let's say prosthetic valves. Okay, so they are known to cause endocarditis following prosthetic valves. What happens is they have surface adhesins with which they will bind to the prosthetic valves, and they will form biofilm, which is actually a protective layer formed by polysaccharide kind of material, and this biofilm layer will prevent the host's immune system to enter into the biofilm, and these bacteria can safely stay inside the biofilm, and they will escape from the host's immune system. So this is a common infection caused by Staphylococcus epidermidis. As you all know, I've been telling about this thing in YouTube as well as my Facebook page, Instagram page. I'm starting to discuss clinical case questions for people who are going to donate $5 or more on my Patreon page. All you need to do is visit www.patreon.com/MadeVids Made Simple and click on Become a Patron button, and you can donate any amount starting from $5 or more. It's okay if you donate $5 also, you'll get access to all my clinical case questions discussions. I'm sure that it's going to be helpful for you guys. You can cancel this anytime you want, so just give it a try once. Check out my blog. I recently made a blog on HLA typing, which is helpful in preventing graft rejection. So this is the link of my blog, www.madevidsmadesimple.blogspot.com. Please hit the like button if you learned something new in this video, and share this video to your friends, and subscribe to my channel so that I'll know that more people really needs my help, and I'll be motivated to make more videos. And also remember that I read comments and I respond to most of the comments, I respond to almost all the comments, and you can request me to make any videos, you can ask me to make any videos. I'll be very happy to make videos for you guys. Thanks for watching. I'll see you guys in my next video.